There's been over 600 cases done. It's the most transfemoral-like of all the alternative access, and there is a high success rate with minimal complications. I mean, this is a safe procedure, but the fact of the matter is there's certain anatomy that can be challenging, and there are still some contraindications. Real quickly, because I get asked this question all the time, is can you do the procedure if the vein's occluded because you have to go from the right? And the answer is sure you can. I mean, here's a case where, I don't remember the story, but for some reason their pacemaker wires had to be pulled down to the leg, and there's a pacemaker in the groin, or I should say in the belly. But so it's completely occluded. So just recanalize it with a wire. Everybody here knows how to do CTOs, IVUS, and make sure that you think you're in the architecture of the vein, but I don't know why you wouldn't be. And then go ahead and balloon the thing open and just get your big sheath in first so that you now know you can at least drive the big sheath in. That's a flex. That's a gore dry seal flex. And then go ahead and do your transcaval through the big sheath. So that's as opposed to putting it in after you cross. And then, of course, at the end, just close it like you normally would, and everything's hunky-dory. And then we got to bill for venoplasty as well. Okay, so how about one, though, that doing a transcaval and one that you know you shouldn't do? So I was asked to do this transcaval, being told that this was a spot that you could go. Look in the upper right there. You know, you'll hear me on a lot of these talks say I love to go through where there's ectasia, but that's not ectasia. That's like a piece of calcified popcorn or something, which turns out to not be the case. So here's if you look at the angiogram, can you see on the right here as we rotate, this is a really focal, heavily calcified. Now, there are three things that go against transcaval here. One is the actual window is tiny. Number two, the calcium juts out here, and I like to go in the bottom third of the ectasia because that's the way the disc is going to come down, but the calcium is completely wrong, so you'd have to go on the top third going around the top. And then the ectasia is not big enough to allow the device to come back. So sure enough, I actually said, we're not doing this one transcaval. We're going to do everything we can to try and go transfemoral. So plan was to use a core valve. So we figured we'd dial up the iliacs, but we couldn't even get a 16 French dilator up the iliacs at all. There we are struggling. Took an 8mm PowerFlex balloon, tried to get a 16 sheath because we were going to use an Evolut Pro, right? And you want a 20 French outer diameter on this sheath. Was able to get a 20 French Edwards dilator up, so we said, all right, let's try the core valve, and no-go on the bareback core valve. That's as far as we could get it. The ballooned it again, really high pressure, tried to get a bigger dilator and a 22 Edwards dilator, and just could not, and said, all right, let's go back to the procedure that we knew would likely be a disaster. The burn's not the problem here. You're going to get across because it's like threading a needle, right? If you're in the right spot, the wire's going to go across. Here we are snaring it. And then we drove it up. But here's what's interesting. We get the wire up, we get a microcatheter up, we swap out to the stiff wire, and I can't pull the microcatheter out. And if you look on the right here, the explanation is where we've actually, such a stiff wire has taken those two things of calcium and actually made handcuffs on the thing. And at least we were smart enough to say, whoa, if we pull really hard, we're going to leave some catheter in the body. So we backed down to the softer wire to actually get the catheter out. But now you got to try and deliver transcaval stuff through a tiny hole above some calcium with a soft wire. And as you can see, this is a disaster waiting to happen. We can't even get the balloon in to do a balloon deal. We eventually do it, 3mm balloon. And you know, here we are trying to push a catheter across something that, just don't try that at home. And eventually taking a Cook check flow and pushing really hard, we did get it to go through. So we were able to get the sheath in and get the core valve in. And Jeff, did I do a good job here on the core valve? It's like my first one. I don't know. Okay, so now we have to close this thing.
You have a future in core valve, Adam. You have a future.
Well, okay, good. So now here's, you can see the problem, right? The plug's not even going to fit in that little tiny spot. So we're getting it as close as we can here. And here we are going to passively expose it, right? So we'll pull it back to propose the neck. But again, you want to get this thing up. So the pressure starts to drop despite protamine. Now you got bowel, kind of shifting bowel. It's hard to tell if there's any bleeding or not. So we said, let's just, pressure was a little soft though. So if the pressure's soft, you assume that there's bleeding. So here's a reliant balloon. Can you see the weird sort of Weebles wobble shape of this balloon, right? It's because the balloon's filling up this tiny little crevice. That's not really the ectasia that I like. Despite multiple inflations, the pressure's still soft, and now we think we have a dissection on the top of that pouch. So we said, well, let's go ahead and put in a graft. And here's a trivascular iliac limb extender. These are self-expanding covered stents, but it's only 45. And so then you could also predict, well, when it's so short like that and it starts to sausage into that little pouch, well, now the ends are bent inwards, so you're not getting the seal that you really want to get with these grafts. So here we are trying to dilate the thing. And in the end, we're like, it's not the best, but the pressure got a little better. So most of these people do okay. And in the end, patient did okay. Here's our final angiogram. You see that little pouch coming off there. There's just not the good flow that you like to see in the IVC. Patient actually came back on day 12 with some back pain. Actually had nothing to do with anything, but we CT'd them. And this is the classic appearance of what that pouch looks like on CT scan. It's sort of a little endoleak. These all heal over time. This patient did fine, but you could predict that this was what the CT was going to look like, and you could predict this complication based on that. So a couple things about CT scanning for these. So, here's the goal. Find a calcium-free spot. Avoid the obstacles. Identify some branches that might be in the way. I mean, these are the goals of CT planning. You have to have a big enough hole to get the sheath in. It has to be able to open a little bit. You don't want bowel. You don't want calcified dissections like this patient. You cannot do that shaggy aorta that's in the middle there. And if it's a really leftward leaning aorta, you're going to skate through the wall a little too far. So we like the rightward leaning aorta, not the leftward. Make sure you're above grafts, things like that. These are things that all make sense. And so in the end, and then know what you need to do. Know how long an endograft you would need if you get into trouble. And then, of course, map out where you're going to go. So in summary, most patients are candidates for transcaval access, but there's a few cases that are predictably unfavorable. I mean, in this case, look, we tried as hard as we could to get across without doing it. And there are some helpful tips and tricks in these situations. And look, we still got away with it, actually. The patient did fine. But it's not one that I recommend that you do early on. You got to understand how the CT works and how to find a spot, select these calcium-free targets, and then ask for help. And we're happy to get you started. Thanks.
Great, thank you.
So, Adam, the stent graft is 14 French, right?
Yeah, so that's a 14 French.
Right,
Well, we've been up
so
with 22
that is-
French dilators, right?
No, but my point is that if you can put a 14 French sheath, you could potentially do
Not
it.
not necessarily, right? I mean,
No,
so
because
so the
I don't know.
Endologics iliac limb extenders, a 12 French capsule. It's pretty hydrophilic, pretty slick. You just need a 3 mm vessel to get it up there, and you could just balloon real quick if you needed to. And so I actually find that that's not necessarily true. That you can deliver a covered stent to places that you can't deliver a core valve to.
Could you,
or go ahead.
no, finish.
You use. I know that nobody likes to hear that, but is it possible to put a core valve through the E sheath? Because I do
Yes.
it. I
No,
have
it
done
is-
it, and
yes,
it
it is
works.
possible.
But of course, it's very hard to find it, and
Yes.
people get a little bit anxious with that.
Sure,
But
you could do it.
you-
but
but-
you wouldn't get a knee sheath across that thing either.
Yeah.
So.
Yeah.
Adam,
All right.
could have you used a different closure device? I mean, was that?
So that was, I think, was that a 10.8 or an 8.6? I mean, there's an 8.6 and a 6.4, but again, you might look, you got a 20 French sheath across with a 24 French outer diameter, and so you need to have some compression, and that's not going to recoil, right? That's a calcified piece of, that's an ulcerated, defect in the aorta. Again, that's not the ideal place to cross, But that patient does fine, so it is doable. It's just not what you want to do on a regular basis. So.
All right, everybody. Listen, I thought those were amazing cases, guys.
Great.
Thank you so much. Thanks for good audience.